Hello, everyone, and thank you all for joining us today on behalf of the Radiologia Society of Rio de Janeiro and OCAD. I want to welcome and thank you all. My name is Aline Serfati, and I'm here with Dr. Hilary Humans, who coordinates and moderates this series with me. Our guest speakers today are Dr. Rodrigo Aguiar, Dr. Diane Flores, Dr. Husain, and Dr. Chari. This session will focus on sports imaging, and the speakers will present their cases, and at the end, we will have a Q&A session. If you have questions at any time during the presentations, please put them in the chat box, and at the end, the speakers will respond to them. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiologia Society of Rio de Janeiro. If you want to join the OCAD community and see challenging cases, consider registering on the OCAD website. And just a quick reminder, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you so much for your understanding, and with that, I will kick off the session. It's my great pleasure to introduce Dr. Diane Flores, a very good friend of mine. She has finished her medical school and residency training in Manila, Philippines. She was a former research fellow in musculoskeletal imaging at the University of California in San Diego, and clinical fellow in MSK imaging and intervention in St. Paul's Hospital in Vancouver, Canada. She's currently an assistant professor of radiology in the University of Ottawa, musculoskeletal radiology and program director of musculoskeletal radiology fellowship in the Ottawa Hospital. Her academic interests are sports imaging focused on knee, wrist, hand, and muscle injuries, and image-guided intervention. With that, please, Diane. Oh, you already shared the screen. Okay.
Yeah. All right. Good afternoon, everyone. What an exciting start to today's session. My name is Diane. Thank you to OCAD, Hilary, and Alini for the invitation to speak today. I am very honored. So I'll be showing a case. All right, so why will I talk about the rectus femoris again? So I understand there are a few iterations of talks about this muscle. First, it is the most commonly injured muscle in the quadriceps. It is a long tendon crossing two joints with high demand for eccentric muscle contraction and percentage of type 2 fibers, making it more prone to injury. Compared to injuries of the more popular muscles like the hamstrings and core muscles, rectus femoris injuries record a longer return to play times and have a high re-injury rate. There is not much evidence-based research regarding the treatment. A study in 2013 found heterogeneity in treatment approaches and quality of studies reporting these various forms of treatment. Conservative and operative approaches can be employed for injury to any component. The authors note that some of the rehabilitation protocols are not even described. Because there is no standardized treatment, clinicians will likely rely on the description of anatomy, which plays an important role in quadriceps muscle prognosis. I believe the anatomy has been elegantly described and illustrated in several prior articles. Perhaps the most famous, and for me, the most representative of these illustrations is by Michael Stadnick in RadSource. Now, the most unique aspects of this structure are related to its two tendon origins, the indirect or reflected head IH, which arises from the supraacetabular ridge and posterolateral aspect of the hip joint capsule, and the direct or straight head DH, which arises from the anterior inferior iliac spine, or AIIS. The rad source illustration does a great job of depicting the cross-section anatomy of this unique structure. The two tendon heads form a conjoint or free tendon about 2 centimeters distal to their origin. The direct head tendon is more fascia-like. There is an anterior fascia, beige in the illustration, appearing as an anterior sheet on top of the unipennate muscle belly. This fascia runs along the proximal 1/3 of the muscle. Another fascia, this time posteriorly located, indicated in the drawing in green, courses along the distal 1/3 of the muscle. In contrast to the direct head, the indirect head tendon in blue dives down to its bipennate muscle substance, forming a comma-like configuration. This tendon is more cord-like, conforming to essentially what we imagine a tendon looks like. It occupies the proximal 2/3 of the muscle. In current literature, rectus femoris injuries are classified into the following. Of these, avulsion, proximal tendon, and indirect or central tendon injuries are often described, while data on myofascial strains and degloving type of injuries are less readily available. Going back to our case, key images show a thickened posterior fascia with associated edema consistent with an acute and chronic myofascial injury. Posterior fascia injury has not been clearly described in literature. Perhaps it is grouped together with the anterior fascia as general myofascial strains. We have collected a few of these cases to possibly describe. They are not common, and our cases so far reflect the observation by previous studies that myofascial injury to the rectus femoris is usually not isolated. The rule is that central tendon injuries are much more important to return to play and rehabilitation compared with the peripheral myotendinous or myofascial injuries, therefore warranting a more conservative form of treatment. We do wonder whether this posterior fascia injury mimics a tear of the quadriceps tendon given its location. Aside from posterior fascia injury, our case had this fluid gap at the distal portion of a retracted tendon. Now, intramuscular degloving injury is a rare injury by my search. There are only 12 in literature, 8 of those belonging to the same source. It refers to a circumferential tear in red between the two components, resulting in dissociation of the inner bipennate muscle indirect head in yellow from the unipennate muscle direct head in blue, resulting in the appearance of a finger being withdrawn from a glove and a fluid gap separating the two muscles. Because this injury is so unique, there is limited knowledge on management and prognosis, and it is not included among the various muscle classifications. This is a nice example, the indirect head inside in yellow with fluid in asterisk, separating it from the direct head in blue. The direct head remains opposed to the underlying vastus intermedius muscle. In contrast to our case, so what you will notice is instead of the withdrawn muscle being only the indirect head, it's actually both direct and indirect heads, and fluid separates the entire rectus femoris complex from the surrounding vasti muscles. So this one is a circumferential tear through the outer unipennate or direct head muscle, separating the entire rectus femoris from the surrounding muscles in red. The only way I can describe this is a finger stuck in a glove being withdrawn from a bigger glove, which is quite a mouthful. So this one, I would rather call it a pseudo-degloving. This has not been described in literature. We have collected maybe less than 5 so far. I think it might be more common than a true degloving, although it can also be underreported or misreported as a true degloving just because of that fluid retraction, and the management is currently unknown. This is a different patient who sustained an injury during squatting in a soccer game. According to the specific surgeon managing this case, this injury is not repairable. I have never seen any degloving type of injury, whether true or pseudo, to be managed surgically. Physiotherapy may also be lengthy, although just like with previous studies, the specific protocol is unestablished. That comma shape of the indirect head tendon is a nice anatomic marker on both ultrasound and MRI. It is echogenic on ultrasound. Here is that comma becoming hypoechoic, consistent with the central tendon or myotendinous junction injury, but there was also fluid separating it from the surrounding direct head in blue, consistent with a true intramuscular degloving injury. This is another case on your right side. I place a normal case on your left as reference. Here is our comma-shaped tendon, again in yellow, and look at the echogenic and thickened posterior fascia in blue, consistent with an injury. Interestingly, this patient was scanned for a quadriceps injury, which was normal. We have seen quite a number of these cases where the quadriceps tendon was normal, but its muscle or fascial components were not. So we do take a quick look at these muscle and fascial components when the tendon itself is normal. That's an important advantage of ultrasound. When scanning tendons, you can easily extend your field of view and even compare to the other side. So in summary, why rectus femoris? Again, injuries of some of the components do not fit neatly into any traditional grading system or classification. Injuries are likely combined and current treatment protocols are unestablished. Probably important to include in an ultrasound scan of the quadriceps if clinical history and location are not typical for a pure quadriceps injury. And for now, anatomy is important to prognosis, so precise description of each component is likely prudent. Thank you very much.
Well, that was a beautiful case. Their images and illustrations are just gorgeous. Hi, I'm Hillary. It's my pleasure to introduce Chari, who trained in Liverpool, where he distinguished himself with a number of academic prizes, and came to Oxford following multiple fellowships at McGill in Montreal and a short interval fellowship at Strasbourg, France. He obtained additional subspecialty experience in trauma, sports, orthopedic, rheumatologic, musculoskeletal, oncological, and spine imaging and intervention. His specialty interests include sports imaging, sarcoma, and musculoskeletal intervention, and he holds multiple interdisciplinary conferences at Oxford. He's a fellow of the Royal College of Radiologists and member of the Royal College of Surgeons. He has his degree in diagnostic imaging from Oxford and a diploma from the ESSR. He's also an examiner for the Royal College of Radiologists. He has taught all over the world and published numerous articles and chapters. Notably, Raj was the organizer of the BSSR 2022 conference in Oxford, which was the first large meeting following the pandemic, and very well attended. And he is the organizer of the popular ESSR sports imaging course to be held any minute now in April 2024 in Oxford. It's the first time it's going to be held in the UK. So that's a big deal. Okay, Raj, please share your screen.
Thank you very much for that kind introduction and invitation, Hillary. Is that okay, my presentation?
You're not sharing the screen.
Oh.
Yeah, now we can see your computer.
Sure. Is that okay now?
Yes, perfect. Thank you.
Perfect. Thank you very much. In the next 10 minutes or so, we will talk about plantaris tendon. I have two cases to show. The first case, sorry, I have no disclosures because there is a commercial product I'll be talking about, but I've got no shares in that product. The first case belongs to a 27-year-old female. She's Olympic 400-meter hurdle runner. She presented with a right-sided medial mid-Achilles tendon pain, which was not responding to conservative therapy such as eccentric loading rehabilitation program. Only relevant past medical history was a contralateral plantar fascia surgery, but nothing to do with the Achilles tendon. On examination, there was focal medial tenderness along the Achilles tendon. Her plantar flexion and dorsiflexion were normal. There was no abnormal tendon bulge. I'm going to show you an example of a normal plantaris before we go ahead and see her ultrasound. Here, that's the Achilles tendon. And right next to the Achilles tendon is the plantaris, and that's the normal relation between the normal Achilles and normal plantaris. I showed this because plantaris was very nicely highlighted because I had done an injection into the paratenon. That is beyond the scope for this talk. Now let's go back and look at our athlete's Achilles tendon. This is medial and this is lateral. This is axial ultrasound image. You see there is a structure which is thickened medially, which is the plantaris tendon. And then there is the Achilles tendon. Compared to the normal, it clearly is not normal here. Now, as we scroll down, the plantaris remains thickened and there is what looks like a cleft between the Achilles and the plantaris tendon. And keep scrolling, we still see the thickened plantaris, and here now the paratenon is also thickened. So this is plantaris friction syndrome. So what did I do? So we injected a product called ostenal tendon, which is 2% hyaluronic acid injection, licensed to inject around the tendons, primarily piggybacking research that is underway in London. That's what I did. So here you see I have my needle coming from medial aspect. The plantaris tendon is right there and the Achilles tendon is there. The needle tip is situated in the cleft, and I started injecting, and you can clearly see the injectate flowing nicely and separating the two tendons. And then I came back and used the needle to get into the thickened paratenon, and I injected into the paratenon as well. Now you see there's injectate between the plantaris tendon, the Achilles tendon, and the injection of hyaluronic acid, which is supposed to be viscous within the paratenon as well. This is the longitudinal view, the nice fibrillar fibers of normal Achilles tendon, inflamed plantaris tendon, and then there is this injectate between them. So we followed up at 6 months. She had excellent response. She was back regular training. She was ever so happy. Otherwise, she was heading towards a surgery. But after 6 months, she had a rigorous training episode in America, which kind of returned her symptoms as she was very apprehensive. So we repeated the injection after 8 months, and she did well. We have not heard anything back after that. So move on to the next case. That belongs to a 21-year-old football player. He plays for the Champions League in the United Kingdom. He's an attacking midfielder, often plays as a forward player as well. He presented with worsening Achilles pain for over a month. In the last 2 weeks, he was experiencing morning stiffness and post-activity pain. The pain was sharp and specifically noticed while jumping or running. He had an MRI scan elsewhere. I had the report for that. The report mentioned thickening of the mid portion of the Achilles tendon and parotinon inflammation. There was intrasubstance signal change in the medial aspect of the Achilles tendon, extending cranially and caudally, and there was a suspected fluid cleft medially. Now, the report did not say whether this cleft was thought to be an Achilles tendon interstitial splitting, or it was a cleft between the plantaris and Achilles tendon. The patient came to me for an ultrasound assessment, plus or minus high volume tendon stripping if necessary, or plus or minus parotinon injection if necessary. So these are the images of the patient, axial ultrasound image. This is medial, this is lateral. As you saw previously, medially, I already see an abnormality. The tendon looks rather hypoechogenic. That tendon is definitely not normal. Now, I don't see a separate plantaris, and I know this is a thickened plantaris tendon. Now, and that's the Achilles tendon. And when we scroll, we see between the plantaris tendon, which is clearly abnormal, and the normal appearing Achilles tendon, we now see a fluid cleft, now very similar to the previous case. And also we notice the parotinon is thickened and it is full house, similar to the previous case. So what did I do? So I went in with a needle, like in last case. So the needle through the plantaris tendon into the presumed cleft. And my routine practice is to go with a needle with a trial injection. There's this syringe filled with local anesthetic, and I inject and I keep injecting. If there is resistance and I can't inject anymore, I do not force, do no harm. Do not create tissue plane. One, it is very painful. Second, it'll make the symptoms worse. So I tried to inject. I was not getting anywhere. I stopped. I came back. Like in previous case, I put the needle into the parotinon and we did the injection. Now here you see the parotinon is massively thickened. The needle is still there. You can see the little reverberation artifacts from the injection, and the plantaris is clearly abnormal. You can see this now because of the fluid window. You can clearly see the plantaris tendon and normal-ish looking Achilles tendon. Longitudinally, some cutting fibers of the normal Achilles tendon, inflamed plantaris tendons, and all the hyaluronic acid we injected in the parotinon. So we followed him up for 6 weeks. He had a good response. He was back for phased training. He was doing physiotherapy and he was doing well, and we have not injected in him since. So talking about the plantaris, plantaris is a small muscle in the posterior compartment of the leg with thin belly and a long tendon. It is considered vestigial. We can live without it. Previously, it has been mistaken for a nerve and often termed a nerve called Freshman's nerve. It is historical, but we know now that it is a tendon. It is true. It originates from the lower part of the lateral supracondylar line of the femur, and also from the oblique popliteal ligament of the knee. It inserts onto the calcaneus medially, either independently or conjoined with the Achilles tendon. The innervation is from tibial nerve, which is S1, S2, and blood supply is from popliteal artery. So talking about the plantaris friction syndrome, we do not understand this syndrome very well. We know it's an entity. We don't know why it happens. It is thought to be a compressive tendinopathy between the Achilles and plantaris tendon, which results in inflammation of the peritendinous tissue. Usually, it starts with thickening of the parotinon and neovascularity in that region, and progresses to the reactive tendinopathy, tendon degeneration, and matrix deposition. When there is matrix deposition, we should be able to see the changes on imaging. On ultrasound, we may see interfibrillary hypoechogenic prominence, like we saw in our examples, or MRI, you should be able to see intervesicular high signal non-fluid sensitive sequences. This is an example from this publication in London, the group in London. On your left-hand top, there is a histology specimen of plantaris friction syndrome, on the left bottom, you see normal tendon. Normal tendon has no significant cellular infiltration, but here the blue arrow clearly shows inflammatory cell infiltration and some mucoid change. So that is plantaris friction syndrome. On MRI, you see normal plantaris here, which is big Achilles tendon, a dot-like plantaris, no inflammation, no paratenon thickening, that is normal. Here you see the plantaris is quite significantly thickened. There is a fluid cleft between the two tendons, and there is significant inflammation of the paratenon. So how do you manage this? The absolute no-no is the eccentric rehabilitation exercise that is usually done for the Achilles tendon. When athletes undergo this rehabilitation, this rather brings the tendons together and worsens the friction. So that's a definite no-no. Instead, the clinicians employ heel raise to separate the tendons and keep the harmony. Often they get non-steroidal anti-inflammatory gel wraps in the region. They get sent for a cortisone injection to the medial Achilles and plantaris paratenon. Again, now increasingly we are trying to move away from cortisone injection because it can be detrimental to inflamed tendons. I'm not saying we don't do them, we try not to do them. High volume tendon stripping has been tried with good results, similar to the stripping of the Achilles tendon. A low volume tendon bracement, again, is very similar to stripping, but with a low volume injection deep to the plantaris has been tried with local anesthetic. And there's another study that's been tried with a bit of cortisone as well. And they also predict good result. The ultimate procedure would be, ultimate treatment would be plantaris tendon resection, which is the last resort. Now, our treatment is hyaluronic acid injection. In the few patients we have done, there's promising early results. Hyaluronic acid is a viscous material and creates a plane with less friction between the two tendons, and the mechanical inflammation settles down. There is a formal research underway, as I've mentioned, and we look forward for the evidence from that. The ethos is do no harm. If the steroid is chondrotoxic, let's try not to use that. Whereas here we have an inert substance which doesn't do any harm, and there is promising results. We could use that. If there is cleft, inject into the cleft and separate the tendons, as I've shown in my first example. If there is no tendon, please do not create if there's no cleft, please do not create a cleft and do harm. Instead, do a paratenon injection, because the tendon surface still gets inflammation. As the paratenon inflammation comes down, the mainstay of the treatment is offloading physiotherapy. What we are doing in interventional radiology is to cut the pain cycle. So with that, I finished my talk. The ESSR sports course is in less than 3 weeks in Oxford, beautiful Oxford. If you would like to come, I still have a last few spaces. Thank you very much.
Thank you very much, Raj. Beautiful presentation. Now it's my turn to introduce my dear friend, Rodrigo Aguiar, who yearly presents in our series. Dr. Rodrigo Aguiar is an adjunct professor of musculoskeletal radiology at the Federal University of Paraná in South Brazil. He completed residency at Hospital das Clínicas at the Federal University, and he did his MSK research fellowship at the University of California, San Diego. He's a practicing musculoskeletal radiology at DAP Clinic in Curitiba. He's very involved in MSK radiology education, having presented at radiology national conferences. He has also authored several peer-reviewed scientific articles and co-authored book chapters. He also runs the 2 YouTube accounts, one in Portuguese that is called Radiologia Ortopédica, with around 11,000 followers, and the other one in English called MSK Radiology. Please, Rodrigo, share your screen.
Hi, everybody. Can you hear me? Can you
Yes.
see my screen?
Yes.
Okay, so it's a pleasure to be here again, 4th year in a row. And I'd like to thank you, Hilary and Aline, for all the invitations, for the friendship that we have, and all the other panelists today. And so let's talk about a knee case today. Today we have a knee case, and my patient, the patient that I'm gonna show you today, is a 19-year-old male that related an intense pain at the intermediate region of the knee after a knee sprain, while playing soccer. He is a professional soccer player. And so he went to MRI. MRI was performed, and on the MRI of the knee, we could see this high signal intensity in this area here, a soft tissue edema medial to the patellar tendon next to the tibia, right here in this region. So here is the sagittal T2 fat suppressed image. Here is the PD without fat suppression. This structure here is the structure that is damaged. This area right here is the area that we can see the edema right here. Okay, so this is the PD without fat suppression. Here is the coronal plane, PD with fat suppression, coronal plane. You can see this area of high signal very close to the patellar tendon, right? Close to the here, close to the tibia. And on the axial plane, we can also see this lesion is not a stir here. Actually, this is a PD sequence with fat suppression. We can see this high signal intensity in this area here. So this is a soft tissue edema medial to the patellar tendon next to the tibia in this region right here. So if we follow this structure right here proximally, we will see that this structure, it continues with the medial retinacular complex, and it goes to the inferior portion or the inferior medial portion of the patella. So that is the structure that we are seeing. So what is this structure, or what is this thing? And this is a kind of a common doubt, right? That's a common question. I could count at least 2 or 3 cases on the OCAD community in the last 4 years, 3 years, that our members, they had this question. Look, this case here, a colleague asking, what is this lesion here? So it's the same question, it's the same structure that I'm addressing here with you today. And the diagnosis is an isolated strain or tear of the distal insertion of the medial patellotibial ligament, right? So that is the diagnosis of this case. The patient, he had pain in the medial portion of the knee. He stayed like 1 week without playing soccer, without training, or just with physiotherapy. And after that, he returned to play. But that was his problem. And this case is an isolated lesion, an isolated tear without patellofemoral dislocation. So that's the rarity, or the rarity of this case, or the unique finding, is that it's not with the patellofemoral dislocation. But one thing that's nice about this case is that we can also use this case to evaluate cases with patellofemoral dislocation, because all here comes down to anatomy. If you know the anatomy, of the patellofemoral, medial patellofemoral ligament, you will crush all the cases of the patellar dislocation. You will see if there is a medial patellofemoral lesion or not. So let's talk about the medial patellotibial ligament right now. So this structure here in green, this is the medial patellotibial ligament. It's part of the medial retinacular complex, with the world famous medial patellofemoral ligament, and with the not so famous, right, medial patellomeniscal ligament. So these are the three ligaments of the medial retinacular complex of the knee. And the medial patellotibial ligament, it shares a common proximal attachment with the medial patellomeniscal ligament right here at the inframedial aspect of the patella. This is important, right? When you see a lesion at the inframedial portion or aspect of the patella, we cannot say if that it's a lesion of the medial patellofemoral ligament or the medial patellomenical ligament. And I'm gonna talk more about that in a few slides. So the medial patellofemoral ligament, it inserts on the medial tibial tubercle. It was described in this paper here in 2018. Robert Laprade and Dr. Arendt they were authors of this paper. It's a dream team writing a paper, and they described this medial tibial tubercle that is located 5 millimeters above to the articular line, to the articular cartilage. This is the area of insertion of the medial patellofemoral ligament. And another important thing is when the knee is flexed, the angulation between the patellar tendon and the medial patellofemoral ligament, it's around 8.3 degrees. They are almost parallel, okay? This is important because sometimes the arthroscopy, the portal of the arthroscopic material can damage this ligament. So here is an image of this paper that I was talking to you. And in this paper, they describe the biomechanics of the structures of the medial retinaculum, and with the extended knee or flexed knee until 30 degrees, the medial patellofemoral ligament is king. 50 to 60% of the function or of the stability of the patella is it comes from the medial patellofemoral ligament when the knee is extended. But when the knee is flexed, more than 90 degrees or more, the medial patellofemoral ligament and the medial patellomenical ligament, they have been reported to be important for patellar stability at higher flexion angles. So in this other paper here, they relate when the knee is flexed, 46% to the lateral translation, 72% of the patellar tilt, and 92% of the patellar rotation. It comes from the patellofemoral ligament and the patellomenical ligament, not from the patellofemoral ligament, right? So here's another beautiful image of this paper here, and showing here the medial patellomenical ligament going to the anterior horn of the medial meniscus. Here's the medial patellofemoral ligament going to the anteromedial tibia. This is the patellar tendon, and the medial patellofemoral ligament is extended when the knee is flexed, and it's medial and almost parallel to the patellar tendon, right? So arthroscopy can cause a iatrogenic lesion because sometimes it passes through the patellofemoral ligament right here. And talking about the origin of the ligament, we can divide the patella in two areas, like the two superior parts or the two superior thirds. This is the area of the medial patellofemoral ligament origin, and the inferior portion of the medial patella, or the like 30 to 40% of the inframedial patella, that's the area of origin of the conjoined origin of the medial patellomenical ligament and the patellomenical ligament and the medial patellofemoral ligament, right? So that is what you have to keep in your mind. When you're seeing the patella, you can count how many slices you can see the patella in the axial plane, and you divide that, and the last 3 or 4 cuts, the lower cuts, that's the more or less the 30 to 40% of the patella, where the conjoined origin of the patellomenical ligament and the patellofemoral ligament is. So here in this case we can see the medial patellofemoral ligament right here, and here this is the medial patellomenical ligament right here. So you can see the two ligaments here. It's easier to see the medial patellofemoral ligament, the medial patellomenical ligament. Sometimes we can see, sometimes you cannot see, but keep in mind this ligament here. the patellotibial ligament. We will always see this ligament right here, parallel and medial to the patellar tendon. So let's go a little deep on the lesions of these two ligaments. And this paper here, they found patients with isolated tears of the medial meniscal ligament, but they didn't mention about the medial patellotibial ligament. My feeling here is that they put these two ligaments together, and they didn't sort out, and they didn't divide these two ligaments, and they just mentioned the patellomeniscal ligament. But here, in my opinion, seeing the paper and the methodology, for me it's the patellomeniscal and the patellotibial ligament. And the patients with isolated lesions of the patellomeniscal ligament, let's say in this case, they had anterior knee pain or a giving away sensation, worse at the terminal knee extension. With the glide test, the normal glide test, the patella was stable because the femoral ligament was okay, was not torn. But when they did the modified glide test, that they pushed the patella superlaterally, they could see the instability of the patella caused by the lesion of the patellomeniscal ligament, and in my opinion, the patellotibial ligament too in this paper here. So it occurs because the patellotibial ligament and the patellomeniscal ligament, they create an opposing vector to the quadriceps tendon right here. So if this ligament is torn, or these two ligaments they are torn, the patella tends to migrate to dislocate superlaterally. Okay, so they found 30 patients with this isolated lesion of the tibiomeniscal meniscal ligament tear. 23 patients without clinical improvement went to surgery, and they had good results with these patients, just addressing this the patellomeniscal ligament in this region here. But again, I think it's patellomeniscal ligament and patellotibial ligament. This is another paper talking about the avulsion of the patellar attachment of the patellotibial and patellomeniscal ligaments, and the patient went to surgery. The patient had a trochlear dysplasia, so it was important to correct the medial patellofemoral ligament lesion, but also the patellotibial and the patellomeniscal ligament lesion as well. So just to go into the last part of this presentation, I'm going to talk about the patterns of the medial patellotibial ligament lesions. The lesion can be proximal, right? So we can see proximal lesions. It can be just soft tissue lesion, or we can see bone avulsions in some cases. We can see distal lesions of the ligaments of the medial patellotibial ligament, and we can see proximal and distal lesions, especially in cases I'm talking about cases of patellar dislocation. So this is a kind of a floating meniscal medial patellotibial ligament with a proximal and a distal lesion. So here's an example of a proximal lesion at the area of the origin of the medial patellotibial ligament and the medial patellomeniscal ligament right here. On MRI, we cannot see very well the bone avulsion. You just see this high signal intensity in the area of the origin of these two ligaments. Again, look the patella: 1, 2, 3, 4, 5, 6, 7, 8, 9 cuts. From here, like if you get this five first cuts here, this is the area, let's say, of the origin of the patellofemoral ligament. Here, the lower cuts, this is the area of the origin of the patellotibial ligament and the patellomeniscal ligament. This is another case, is an avulsion. Probably there's a bone, the cortical bone is here, avulsion of the cortical bone here at the origin of the patellotibial ligament and the patellomeniscal ligament right here. So it's a proximal lesion that we can see here in this case. The patient also had edema at the insertion of the distal patellotibial ligament, but very weak. Okay, not so impressive in this case. But look this case here. Another case of patellar dislocation, complete tear of the medial patellofemoral ligament, patellar impaction fracture here in the distal third of the medial patella. But look here at the insertion of the medial patellotibial ligament, completely torn, right? There is a complete tear of the insertion of the medial patellotibial ligament. Look here, look. We can't see the ligament right here. We can't see the insertion of the ligament in this region, a complete tear, a distal tear of the patellotibial ligament. And this was a case that was sent to me by my friend Eduardo Bervian here from Brazil. And this patient has also a proximal lesion of the conjoined tendon, or the conjoined origin of the medial patellotibial ligament and the medial patellomeniscal ligament right here, with this bone fracture associated in this region here. But look at the insertion of the medial patellotibial ligament right here, a massive distal patellotibial ligament avulsion right here. Okay, so about surgery, there are papers that they analyze the correction or the combined surgery of the patellofemoral ligament and the medial patellotibial ligament, and they describe that it's a good option. The results are better than just the correction of the patellofemoral ligament. But here in Brazil, for example, is something that I haven't seen much. Okay, I just see surgeries of the patellofemoral ligament. I don't see surgeries addressing the patellotibial ligament. So now what I want from this presentation today is that you get confident, that you know how to evaluate the lower ligaments of the medial retinaculum, especially the medial patellotibial ligament. It's easy to evaluate. You just have to know the anatomy. If you know the anatomy, you crush. You get all the cases right. Okay, so that's it for my case today, and thank you again for the invitation.
Okay. Thanks, Rodrigo, for pointing out new anatomy that I now can ensure in the future. Okay, wrapping it up, we have Rola Husain, who is a diagnostic and interventional musculoskeletal radiologist consultant in Bahrain. She's a graduate of the Royal College of Surgeons in Ireland Medical University of Bahrain, and a holder of the Arab and European Boards of Radiology. She completed 2 MSK radiology fellowships, both at Mount Sinai Hospital in New York and Vancouver General Hospital in Canada. She's the secretary of the Arabian Gulf Society of Skeletal Radiology and their representative at the Asian Musculoskeletal Society. Most importantly, I recently had the pleasure of meeting Rola in person at the Society of Skeletal Radiology meeting in Puerto Rico, and at our most recent OCAD live meeting, which was definitely too much fun. She presented a crazy fabulous case at OCAD Live, and I'm thrilled to have Rola back presenting for a second time in this series. Okay, we need to make up a little time. Hit it.
Hillary, she's asking to.
I think it's good now.
It's good. It's good.
Oh,
Perfect. Okay, so are you seeing the screen?
yes.
Yes.
Perfect. I'll try to go fast. First of all, thank you very much, Hillary, for the kind introduction. Thank you, OCAD. Thank you, Hillary. Thank you, Elena, for having me again. All right. Before I start, I want to give special thanks to Dr. Marcelo Bordallo for providing me with the cases for today, and of whom I have worked with last year. All right. So for our first case of today is a 32-year-old male handball player with an injury he has acquired during a World Cup championship. All right, this is a coronal T2 facet. Again, there's no significant changes seen within the vicinity of the shoulder. However, as we go more inferiorly, we start to see some architectural distortion and edema within the vicinity of the inferior sternal head fibers of the pectoralis major muscle. Now, this is the axial T2 facet. Again, you see this trail of edema tracking along the myotendinous junction of the pectoralis major muscle. And also you see normal insertion of the tendon into the humerus. Okay, this is the sagittal T2 facet showing the partial thickness injury of the myotendinous junction of the pectoralis major inferior sternal fibers, with the developing associated with the hematoma, and again, normal insertion into the humeral bone. Great. This is the second companion case. I'll quickly go over them, and then I'll give you a quick overview of this entity. So this is a 32-year-old weight lifter who acquired pain while lifting weight 3 days prior to the time of presentation. So this is axial T2 facet. Again, as you can see, there's some feathery edema along the muscle fibers of the sternal head as well as the clavicular head of the pectoralis major muscle. As we go more inferiorly, it becomes more and more serious. We start to see a partial thickness tear involving the superior sternal head fibers as well as the clavicular head. And as we go more inferiorly, it starts to involve the inferior fibers of the sternal head of the pectoralis major, extending to the myotendinous junction in a high-grade partial thickness fashion. The site of insertion into the humerus is again contact as much as the first case. Great. This is the coronal T2 facet, again representing the partial thickness high-grade injury of the muscle belly of the clavicular, as well as the superior sternal head fibers. And as we move more inferiorly, we start seeing involving the inferior sternal head fibers extending to the myotendinous junction with the associated with the hematoma formation. And this is the sagittal T2 facet, again, partial thickness injury of the muscle fibers extending to the myotendinous junction with intact insertion into the humerus. Great. I'll give you a quick overview about pectoralis major injury. This is quite a rare entity. However, its incidence started increasing since 1960s because of increased popularity of certain sports that has high frequency for this type of injury. Now, injury can occur in one of two ways. It could be indirect, and usually this happens on weightlifters, in particular during bench pressing, and especially within the downgrade movement and within the last 30 degrees, when there is eccentric loading on already tensed muscle. Or it can happen as a result of a direct blow, either during football, water skiing, wrestling, martial arts, boxing, American football, rugby, gymnastics, or parachuting. Now, I know that the diagnosis is usually made based on clinical basis. However, imaging plays an important role, and not only in assessing the extent and the location, but also in determining the mode of management. Now, the pectoralis major muscle is a fan-shaped muscle, and it's made up of 3 parts. We have the clavicular part, which arises from the inner 1/2 of the clavicle. We have the sternocostal arising from the manubrium, sternum, and the ribs. And then we have the abdominal head arising from the external oblique muscle fascia. The sternocostal is divided into superior fibers as well as inferior fibers. Now, I know that I already said that it has 3 heads. However, the tendon itself is made up of 2 layers. Now, the layers is, first of all, we have the superficial layer, which is made up from contribution from the clavicular, as well as the superficial fibers of the sternal head. And that would insert into the humerus. Whereas the posterior fibers, or the deeper one, are made up from the contribution of the inferior fibers from the sternal head, as well as the abdominal head, and that will undergo 180 degrees, and then will insert below the superficial fibers in a more proximal location. All right, as we said, 2 layers of the tendon that will form a U-shaped configuration, superficial and deep, both of which will insert lateral to the bicipital groove. Again, the anterior fiber is made up of the clavicular, superior aspect of the sternal head, and then the deeper and more posterior one made up from the inferior aspect of the sternum, as well as the abdominal head contribution. Now, injury can occur any place, either from site of origin of the aforementioned bones, or the muscle belly itself, the myotendinous junction, the tendon itself, or even at the site of insertion into the humerus. I know the anatomy of this area is a little bit tricky and complex, so I'm trying to simplify it with a bit of tips and tricks. Okay, so this is within this section, you see that the pectoralis major is the most anterior muscle, and it's separated by the deltoid by the deltopectoral groove. What lives there? The cephalic vein. So that's an important landmark to separate the pectoralis from the deltoid. And again, as you can see, the pectoralis major is anterior to the minor, as well as the long head and short head of the biceps, as well as the coracobrachialis. Great. Now, for the tendon itself, how are we able to tell this is the superior part and that's the inferior part? So a simple trick is that, how can I tell this is the superior aspect of the tendon? Is once I start visualizing the quadrilateral space, or in other words, once you start visualizing the triceps. So whenever we see the triceps tendon, we know that we are within the superior most aspect of the pectoralis tendon. How can I determine the inferior most aspect of the tendon? Is that I know that it ends right before I see the deltoid tuberosity. So that's another useful trick. So whenever we're suspecting an injury, we need to plan our scan. Let's just make sure that we include it within our planning. Now, how does this injury take place? Muscle goes under extreme tension, usually under extension and abduction, with application of extra additional forceful stretching. The patient usually hears a pop, as you can also see in this video. When the patient presents, this is usually axillary and upper arm ecchymosis and swelling. As you can see, there is some asymmetry within the pectoralis musculature. There is thinning with loss of axillary fold. And another trick is that usually the side where there is a suspected injury, the nipple will be seen slightly inferior to the contralateral side, which they basically refer to as a sagging nipple sign. The patient might also have pain and decreased range of motion. Now, where would injury take place? It can happen at the site of origin of any of the aforementioned bone or within the muscle belly of self. Usually this happens in the setting of a direct trauma. Or, just like in our both cases, it can happen within the myotendinous junction, making up to 25% of the cases reported in the literature, or within the tendon itself, or at the site of insertion into the humerus. And depending on the severity of the injury, it can take a chip of bone with it. Now, imaging. Ultrasound is quite good in order to diagnose this entity, especially that's widely available. The pathology is usually depicted as disruption of the fibers, absence of the tendon or the muscle, retraction, hematoma formation, and of course, altered echogenicity of the muscle. Due to the constraint of time, I won't be able to walk you through the technique of how to diagnose it or find the anatomy on ultrasound, but please, in the recorded session at your leisure, this is basically beautifully depicted in this article. All right, so this is a normal pectoralis tendon, echogenic and beautiful. Comparing it with a full thickness tear with retraction, in this case, with its corresponding image on MRI, as you can see, there's a full thickness tear with avulsion from the site of insertion of the humerus, and there is retraction of the tendon. As well, you can see that there is medial dislocation of the biceps. It's free. There is nothing tucking it in place anymore, so it basically dislocates more medially. What do we see on MRI? Usually the telltale sign of a pectoralis injury is the presence of edema and hemorrhage, and that will bring our attention to the site of tear, also known as a trail of smoke sign. This was published in Journal of Radiologia 2021, and they stated that it's 100% sensitive and is specific for acute humeral tendon avulsion or pectoralis major tendon tear on shoulder MRI. In some setting, the patient presents with symptoms, but the orthopod will send it it to rule out as shoulder, will send it as shoulder MRI request. But once you pay attention that within the vicinity of the pectoralis, there could be some edema, this will draw your attention that something is cooking. Maybe we will go back and widen our field of view and find more pathology. Others, a sort of pathology could be seen as a gap or a defect, muscle retraction, or a biceps dislocation. Injury can happen in many flavors. It could be a simple strain with edema, or it could be a partial thickness tear with a hematoma, or it could be as a full thickness tear with retraction. This is an example of a 20-year-old man who had a muscle injury, grade 2 sprain with a partial thickness defect involving the inferior clavicular and the superior sternal heads of the pectoralis major. All right, so what should we include in our radiology report? First of all, normal, abnormal. We know there is a pathology. Where is the pathology? Is it involving the muscle, belly, site of insertion into the bone or the origin, the myotendinous junction, intratendon, or the tendon insertion of the humerus with or without bony avulsion? Secondly, is it a partial or a full thickness tear? And that's usually evaluated on the amount of thickness loss on an AP dimension, or whether it is a complete versus incomplete tear, and that's usually determined on measuring the amount of defect on the craniocaudal dimension. In conclusion, rupture of pectoralis major musculotendinous junction, unit is quite rare. However, it's basically increasing in frequency due to increased popularity of some sports that has higher frequency for this type of injury. Imaging is quite important, especially that the physical examination in acute setting could be a little bit limited, and early detection means early management, and thus will result in better functional and cosmetic result. Thank you.
Thank you so much, Frola. Hillary, you asked the question to Diane. She put on the chat. Do you want to talk about it?
Yeah, I just had the one
or two
question. If I had seen that, I think I would have been tempted to call it a complete rupture of the rectus femoris at the distal myotendinous junction with fluid surrounding the torn muscle and tendon within the sheath. I mean, like we often see with the distal biceps.
Yeah, I think I would probably add in the retraction. For now, I don't think there is any difference whether we say it's retracted or not, just because there is no established form of management. But I think in the future, when we know more about the management of these injuries, the retraction, similar to other tendons, might indicate the return to play, whether they have a longer rehabilitation. So, for example, in this case, this patient had that a lot of retraction. So this patient was actually referred to an orthopedic oncologist because it presented as a mass and not just a classic traumatic injury. So, I mean, it's more of semantics, I guess. And also the term pseudo-degloving sounds much nicer, but I agree. It is a complete tear of the distal myotendinous junction.
Thank you.
No problem.
Hillary, I don't know what happened in my computer. Can you please check the chat? Because it's not working.
I don't see any other questions. I would we've run a little bit long. A lot of people had a lot of things to say. So if anybody has any particular questions for the speakers, I'd encourage you to contact them directly or send it to me or Aline and we can pass it on.
Yes. And I want to thank you all for tuning in today. The next session will be on April 19th with focus again on sports imaging. See you then. Bye-bye.